my dear friends, ladies and gentlemen. I am Dr. Shailesh A. Shah, a urologist in city of Ahmedabad. Passing urine is a pleasant phenomena. All of us do not realize it till the problem occurs. Today we will discuss a case report where after the surgery patient could not pass urine. So here is a case presentation. 55-year-old female presents with complaint of urinary hesitancy, frequency and incomplete bladder emptying following surgery. She reports difficulty initiating urination and sensation of complete voiding despite multiple attempts. She recently underwent a hysterectomy for uterine fibroids. By history, fibroids with symptom of pelvic pain and there was a heavy menstrual bleeding, what we call a menorrhagia. The hysterectomy was performed under GA, general anesthesia, which lasted approximately 2 hours. There is no known history of neurological disorder or even diabetes mellitus. The initial treatment given post-operatively by managing the distended bladder by doing a catheterization so that the urinary retention is relieved. She was initially prescribed pain medication and advised to perform pelvic floor exercise. However, despite catheter removal and conservative measures, she continued to experience voiding difficulties.
What is the probable diagnosis and the differential diagnosis in this case?
If you consider the diagnosis, we need to do a urodynamic study. In this patient, it had revealed detrusor underactivity with decreased bladder contractile function, and there was an increased PVR. Other potential causes of voiding dysfunction such as bladder outflow obstruction were ruled out by doing this study.
Based on your clinical experience, is post-operative detrusor underactivity a frequently encountered complication? If so, which types of surgeries tend to be the primary culprits?
Burden of post-operative urinary retention is high. It is variable. Like if you see the reported incidence, the range is varied between 5 to 70%. So it depends upon how do you select the patient. There are multiple factors in etiology which depend upon the type of anesthesia, type and duration of the surgery, underlying comorbidities and drugs used in perioperative period. The perioperative period can disrupt normal micturition physiology due to various factors such as anesthesia, surgical procedure, physiological stressors, medication, pain, and anxiety. Drug used during the perioperative period, including sedative, analgesia, anesthetic agent, can interfere with the micturition pathway. Opioids in different form are commonly used for intraoperative and postoperative pain relief. It can lead to urinary retention by reducing bladder sensation and increasing the sphincter tone.
What is your approach when it comes to managing post-operative detrusor underactivity? How would you manage this case?
This is the female who had got a post-operative voiding trouble, and as I said earlier, UDS has proved underactive detrusor. I would like to give a Bethanecol, which is initiated at the dose of 25 mg orally 3 times daily, and it can be gradually titrated up to maximum of 50 mg 4 times daily based on the patient response and tolerability. Patient is explained about the mechanism of action of Bethanecol in stimulating bladder contraction and improving voiding efficiency. Treatment response after 2 weeks is seen, and in this particular patient, there was a significant improvement in voiding symptom. She experienced a reduction in post-void residual urine volume and more effective bladder emptying. She tolerated the medication well without any adverse effects.
What are the challenges or drawbacks of empirical treatment in post-operative detrusor underactivity?
There are challenges with typical management. When there is an underactive detrusor, we have to do a urethral catheterization. Either you do a continuous or you do intermittent self-catheterization, which we call as clean intermittent self-catheterization. Now, typical bladder dysfunction management, when you do with the urethral catheterization, the infection, UTI, is a problem, and there will be decreased quality of the life because of the UTI. Up to 20% of the patient required urethral catheterization for more than 2 weeks. Now it means here SICC doesn't work, so you might have to put the catheter for more than 2 weeks, and about 15% will need it for about a month, that is 4 weeks. Previous research indicates that need for permanent catheter in small group of the patient is required. Either you keep on changing the catheter every 3 to 4 weeks, or you do a suprapubic catheter. This is because of the neurogenic bladder, you require at least in 1.5% of the patient.
How does the Bethanecol function in the treatment of post-operative detrusor underactivity?
The Bethanecol chloride has a potential effect as a cholinergic drug, and it is considered for treating patient with high post-void residual urine without bladder outflow obstruction. Bethanecol chloride is believed to enhance detrusor muscle contraction, which will lead to higher maximum flow rate, higher detrusor pressure at maximum flow, and ultimately it will reduce the post-void residual urine.
What evidence supports the effectiveness of Bethanecol in managing detrusor underactivity following surgery?
The evidence is the scientific paper. This paper, there is already paper published in International Journal of Urologynecological Cancer, where there is a randomized controlled trial study of Bethanecol chloride for prevention of bladder dysfunction after the radical hysterectomy. This study has reflected really good result in the patient where there was a suspected bladder dysfunction, so it was given for the prevention of the retention. Bethanecol itself decreases the time for catheterization. Now in this particular study, 70% of patients had their urethral catheter removed at 1 week, while the control group removed in 38% of the patient. So overall, if you look at the effect of the Bethanecol in this particular paper, which is international paper, it decreases the time for catheterization and the effect starts immediately. The most important point which I want to stress is that most of us will understand that the Bethanecol will have an effect like paracetamol. You take the paracetamol and fever goes, but it is not like that. The study says that all patient could completely emptying the bladder without a high PVR, and it is not that when you give the drug there will be effect. Many of the patient will have, especially the case which we are discussing is post-operative underactive detrusor, where you give a drug for 1 month to 3 months, but it will ultimately permanently normalize the voiding function.
What are the typical dosing regimens for Bethanecol in post-operative detrusor underactivity?
I have been using Bethanecol since long. In Indian market, we get 25 milligram and most of our patients easily tolerate 25 milligram 2 times a day initially, and then if they tolerate well, then we increase to TID. Later on, we can give even 50 milligram 2 times, and then there is a long-acting ER product available which is extended release product, so we give it for 3 to 6 months. The problem is this drug also works on the gastric cells, and therefore I prefer to give to the patient at empty stomach. So maybe 1 hour before the meal or maybe after 2-3 hours of the meal, and therefore they will not have a nausea and vomiting, and they will tolerate well. There are some female and younger female and younger male who may not tolerate well. At that time we give a half tablet 3 times a day about 1 hour before the meal. But in practice these are very rare occasions. So overall we have a quite versatility as far as the dose is concerned, and most of the patients do very well with the higher dose also, and accordingly not only temporary but their detrusor activity permanently becomes all right, and that is where the cure is given by a consultant urologist.
What monitoring parameters are important to assess during Bethanecol treatment for post-operative detrusor underactivity?
Here we are talking about only post-operative underactivity. I will first answer about post-operative underactivity, but overall any type of underactivity, because nowadays there are wonderful drugs for a bladder outflow obstruction for BPH, and even in a female bladder outflow obstruction one use alpha blocker. So when you keep on using alpha blocker, so many patients keep on using alpha blocker without prescription from the urologist or a surgeon or a physician, and over the time that bladder becomes underactive. So that point is a different point, but here as the question has popped up that what care and how do you manage when you give the drug. So I will certainly ask the history of asthma and COPD, hypertension, cardiac disease and Parkinson disease. As we discussed, it works on M3 receptors, and therefore these are the diseases in which we have to be careful in giving the drug, and especially when you are escalating the dose, at that time you have to be pretty careful. As I told that it is working on the gastric parietal cells, I monitor the patient because sometimes patient will get a vomiting and they continuously get a nausea, and they don't know because there are 2-3 drugs they are taking, so which drug is responsible. So we should preferably ask the patient to take the drug at the empty stomach or at least 2-3 hours of taking the food. So these are the criteria by which I will monitor the dose of Bethanecol hydrochloride. Now the patient who are having an underactive detrusor, which is not actually a post-operative but it is a primary underactive detrusor. Remember that there are a large number of patients who are idiopathic primary underactive detrusor. They come to us, they go to urologist, and it is an underdiagnosed disease. Till you do a urodynamic study, you don't understand that this is a primary idiopathic underactive detrusor, and this patient are benefited both by combination of alpha blocker as well as Bethanecol hydrochloride. Some of them who are having a very severe primary underactive detrusor do need self-clean intermittent catheterization, but in my experience it is usually required for couple of days to weeks, and after that Bethanecol tablet takes care of the patient and they do well. So one is a post-operative underactive detrusor, second is a primary underactive detrusor, third is a patient who are on a self-medication, or as you see the physician when they see a geriatric patient, if they write down alpha blocker, patient keep on taking for years together with his or her diabetic and antihypertensive drug. So over the time their bladder is decompensated, so the detrusor function is less. In this situation also Bethanecol hydrochloride works. I have used when this was not available even in India, and there was an international brand was available under the grey market. Now all of us are lucky that at least it is easily available in different strengths.
Doctor, can you please share your personal opinion on result appear in underactive bladder patients on usage of Bethanecol chloride?
Ladies and gentlemen, we discussed the underactive detrusor in the post-operative case. I earlier told that there are other underactive detrusor also. I have been practicing since 40 years and I was professor and head of the department in Kidney Institute, and several students are following what I practice today. We have a referral urodynamic center also, so I do get a lot of urodynamic, especially patients who are just operated by gynecologist for hysterectomy or a cesarean section or something else, and even a minor DNC also sometimes. After that they go into the retention of urine. So we do a urodynamic study in that and find out what is the reason. Moreover, we are a referral female urology center, and therefore the congenital condition like female hypospadias, female epispadias, female urethral stenosis and urethral stricture, neurogenic bladder, these are the different conditions in which, even in case of the condition like stress urinary incontinence, where very frequently the sling procedure is done. So if you do a sling procedure at that time, the stress urinary incontinence will be reduced, but over the time the bladder becomes underactive, and therefore they struggle a lot and they are not able to pass urine. So this group of patients, like where you have a female epispadias or a hypospadias, in India, because of the ignorance as well as in the family, the female is given the last attention as far as the health is concerned. So we come to know about hypospadias and epispadias at a very adult age, and when we do urodynamic, we come to know that their bladder is underactive. So if I reconstruct only the urethra, they are not going to become all right. So I need to give them a drug which can contract the bladder, and therefore these are the patients who will be on Bethanecol hydrochloride for very long time. Some of them are for 6 months to 1 year also, and they tolerate it very well, and over the time the residual urine remains less and less, and sometimes it disappears. So the case which was discussed here was a post-operative underactive retention, but according to me there is a large scale of the patient who are usually benefited where they have a voiding trouble, and especially in female, if they just come and complain about frequency, urgency, urge incontinence, do not understand that it could be just an overactive detrusor. Sometimes underactive bladder patient will also come like that, and you need to do a urodynamic study if your primary therapy is not working, and if it is an underactive detrusor. At that time, after urodynamic study, Bethanecol will certainly give result in such group of patients. Thank you.